Okay, our presenter today is Athena Chapman. Athena is president of Chapman Consulting, where she provides strategic planning, meeting facilitation, and organizational support to a variety of healthcare-related organizations based on her experience working for the Centers for Medicare and Medicaid Services, the Department of Healthcare Services, and as the Vice President of State Programs for the California Association of Health Plans. And with that, I'd like to welcome our presenter for today. Athena, welcome.
Great, thank you so much. So we'll go ahead and just jump on in. We have a lot to cover and we want to leave plenty of time for questions. So this presentation, as mentioned, is about the role of community-based organizations in healthcare and how health plans can leverage their expertise in order to provide better access and services to social services and supports. And so it starts with the premise that community-based organizations do have an important role in healthcare and that they are trusted organizations within the community that can help meet non-medical needs of members, such as modifications to the home or recuperative care placement. And so there is plenty of evidence to support the theory that community-based organization and health plan partnerships do help members avoid more costly medical treatment and result in more person-centered care, which of course leads to better health outcomes, something that everybody is driving towards. And so the SCAM Foundation and myself thought it was important to look at how we could examine how to make these partnerships more successful, see which ones have been successful, and what kind of things we can do to move these partnerships forward. So looking at successful partnerships, we did, through the development of this issue brief, there was interviews with several community-based organizations that had had some level of contracting or partnership with health plans to talk about their experience, what worked, what didn't, and then also some conversations with health plan leaders and an all-day strategic planning session with health plan leaders to talk about those experiences that had worked, some of the barriers and challenges that we'll get into. And so just as sort of level setting, there was a set of services that folks identified as sort of the low-hanging fruit, so to speak. And so those are medically tailored food delivery, intensive case management for behavioral health and homelessness, home modifications, and transitional recuperative care. So those are the ones that folks that we talked to on both sides were able to identify as specific activities where they'd found it easy to create these partnerships, found some successes. So these are ones that would sort of be the starting point for successful partnerships, although not to say other services couldn't be, but these were just the ones that were identified as areas where there had been success. So in talking about the steps to a sustainable partnerships, we have just a list here. We'll run through the list of items that came to the top as we went through this process, and then we'll talk about each one in more depth as we go through the presentation. So the first one is you have to have a commitment from the health plan and CBO leadership. You need to agree on a discrete set of services so everybody knows what's being provided and what's being paid for. You have to communicate expectations up front, address infrastructure needs and costs, as this is often new to both parties. And then we have a few more here. We'll go into each one in more detail in a minute. Design mutually beneficial payment arrangements. Develop organized structure to promote coordination amongst the entities, build in referral capacity, and use data to drive internal and external changes. So that's the high-level overview of the steps that were identified as really being key to making sure that these partnerships can be built, can be beneficial to both sides, can result in return on investment for both sides, and have the outcomes for the members that we're looking for. So going into each one a little bit more detail. So first, commitment from health plan and CBO leadership. So to even get started, you really have to have buy-in from the top of the organization in order to make sure that the resources are going to be appropriately allocated, that folks are going to know that their leadership's going to give them the support that they need, because it's often very complicated and you may hit barriers along the way. So really knowing that the organization is committed to this partnership from the start makes a big difference, and will help leadership understand that they may have to change course a little bit, or provide resources they didn't expect, or make changes. And so if they have that, from the start, real buy-in on the concept, then it makes it easier to adjust as necessary as those things come along. A second piece of that is that there's lots of competing priorities. So this issue brief was focused on what health plans can do. So it says health plans have competing priorities. We know community-based organizations also have competing priorities, and so there is a real need to show the return on investment up front, and that's been a real challenge in these partnerships, I would say. In the work that I did here and in just other work around this, it really is important to have it be part of a longer-term strategy, because you may not see it on day one. So that ties back to, if the leadership is invested in this as a long-term strategy, then you don't necessarily have to show a return on investment financially, in the first phase or right off the bat. That there's a understanding that this may take longer than some other plan investments that they may make. So identifying a discrete set of services, this came up a lot, in that, you can easily just say, oh, well, we want to provide social services and supports, and that can be a really expansive list. And so folks on both sides really made it clear that it was important to know up front, what are we going to serve? What services are we aiming to provide? And that's important for the health plan, because they want to know what they're going to be able to provide to their members and how it fits in with the rest of what they're doing. And if it's a specific unmet social need that they're really trying to target, so that they can really focus that in. And it also will help the health plan determine if the relationship's going to require that the community-based organization be part of the actual network, or if they can have a more informal relationship where they just maybe send referrals to a food bank or something that doesn't require it to be part of the formal network. And I think it's also important we'll get into this a little bit more in one of the next slides, but for figuring out how to develop a rate. So for a community-based organization, a health plan, to start those negotiations about how you're going to pay for these services, because obviously there's a cost to the community-based organization for being this partner, that if you have a discrete set of services, it makes it easier for folks to think about, how do we package that into something that we can then charge for appropriately. So communicating expectations up front. So there was a lot of discussion around the development of maybe a request for information, which could help do things like identify that discrete set of services. It can really help plans identify which community-based organizations are really meeting their needs. So maybe your community-based organization has a certain just set of services, but that's not what this plan is looking for, or vice versa. And so it's important to think about, how can you, both sides, communicate up front, what is the health plan looking for, what is the community-based organization able to offer, and do those two things align. And so one concrete suggestion was to develop an RFI, so that the health plans and the community-based organizations could see that more plain and black and white on the paper, to figure out which partnerships might be the most viable. And so then a health plan could take that information to structure an RFP that would target the specific CBOs, the varying degrees of sophistication that they may need, and make the requirements really specific, so that they know they're getting the right type of CBO that will fit within their model and meet the needs that they have identified. So addressing infrastructure needs and costs. I talked a little bit about this already, but I think this is an important one. So obviously, plans and CBOs will need to be able to share data, invoice and pay for services, and build internal organizational and referral processes. And we'll talk a little bit more about the referral process later, because that became a real pain point in a lot of the conversations that we had. about folks' experience. But to focus on the first part, so there's obviously a need to be able to share data may require some actual building of systems. It may require ways for the programs to talk to each other. It may require actual staffing on both sides or one side. The CBOs may have to build infrastructure in order to be able to invoice a plan like a regular provider would. The plans need to be able to build and pay for the services. So both organizations need to be able to do an analysis of what does it really cost to get this up. It's all great to have a contract that says we're going to provide this for this amount of money and you're going to pay us. But there's a lot of behind-the-scenes infrastructure, and it came through a lot in our conversations that was a real barrier. If that wasn't done right up front, then you really ran into a lot of problems on the back end because folks didn't quite understand what it was that we needed, they needed internally to make it all work. So I think, again, that fits in with like an RFP process where those things would be maybe outlined, and if a CBO felt like, wow, that's too much for me to take on, or I'm going to need to ask for additional funding to really make those infrastructure changes, that can all be done up front and in the light of day, so to speak. So I think that's a really important point to make. But the integrated model does offer the potential to spread the startup costs across multiple payers. So there was some discussion around maybe doing, if you have a solution that works, you can think about maybe leveraging different payers, so the county, the state, the federal government, health plans. So if you are working with all of these payers, then maybe thinking about, well, if I'm going to do it for one, I could potentially leverage it for others, and so that can make it a little bit more feasible to maybe spread the cost across several payers, since the system does involve a lot of those different payers depending on who you're serving, and so not one payer has the burden of the entire cost. So this idea of thinking about all the payers that you may potentially serve as a community-based organization, and a health plan being one of them, is there a way to leverage some of those costs across the system so that you can build the infrastructure you need and use it across the system, which of course would make sense if you're going to build something to have it work across the system. So designing mutually beneficial payment arrangements. I touched on this, but again, it goes back to if you outline up front in the RFI and RFP process, what are the services and what is that going to cost? Then you can start to think about how do we design payment arrangements that reflect the needs of both parties. So do you do some sort of, fee-for-service arrangement, or does it make more sense to say a capitated arrangement? There was even some discussion around designing programs that are around sort of a grant funding model, so you would just give a lump sum of money and ask for certain things. Is there a way to build in incentives and pay for value? And all those are options, but they need to be mutually beneficial. So both sides need to understand what they're getting into, feel like it's giving the value that they need while allowing the services to be provided to the members. And so one thing we heard a lot was just that there was not a lot of good data or recognition about the actual cost projections, because we're sort of in newish territory of how this is so integrated into the healthcare system at the health plan level. And so really being able to look at as much data as possible to make valid cost projections, and then think about ways to build in, once we implement, let's go back and see, were we right, were we wrong, is this working for both sides, and not just be stuck with a certain structure or a certain amount if that ends up in reality not being what is actually reflective of the true cost, and allowing those services to get to the member. So developing organized structure to promote coordination. So obviously this is at the core of building these integrated models. And so there was a lot of discussion with the health plans about then when they get sort of a traditional provider, there's an onboarding process that this is how it works, this is how you invoice, these are the utilization management controls, these are all the things that a traditional medical provider would receive as they were joining a health plan network. And so there was a thought that it could be utilized, something similar would be really helpful for community-based organizations, for both sides, of sort of level setting and expectations, and to really figure out, that a strategy to design sort of an onboarding process for CBOs, which wouldn't look exactly like what a traditional medical provider does necessarily, but there was a thought that was a good place to start as a template. So I think just understanding that if you don't do these things up front and the CBOs don't understand how health plan works, then they're really just setting themselves up for failure. And so it's really the responsibility of the plan to think about what information does this community-based organization need? What have I learned from my contracting with other providers and other entities that could be leveraged here? And then building in a referral capacity. So we touched on this earlier as well, but I want to kind of build in some additional time to talk about this because it came up a lot. It came up in almost every single conversation I had with the community-based organizations. It came up in the health plan discussion, and that really, it was unfortunate. We heard about several partnerships that failed because everything else was set up, it looked great, and then the community-based organization sat there and never got a referral or got one or two, which of course, if you're going to be building infrastructure and thinking about changing your business model to work with a plan and then you only get 0 to very few referrals, it's really not worth it, and that can be very frustrating to both parties because everybody's put in a lot of time up front to build this up and get it going, and then nobody's going where we intended. And so there was a lot of discussion about how to build referrals into the workflow process. So as plans now, right, you go into your doctor, you need a referral to a specialist. That's built in. It's a workflow. People understand, the case managers understand, the actual systems are, set up to work that way and flag referrals and follow up on them. And so that needs to happen with these services. And so that's something, again, that takes infrastructure and time and lots of back and forth to develop those workflows and make sure they're happening on both sides. But I really can't emphasize enough how much this came up and how frustrating it was for both sides when they'd done everything to launch a partnership and then nobody ended up where they were supposed to be. So I think it's really, it's just really important to acknowledge this and think about how those barriers could be reduced. And so again, there was a lot of work about, a lot of discussion about how, case managers might not know that this resource is available, or staff may not know it's available when somebody calls in to the health plan. And so really just integrating it in. The health plan needs to make sure if they're going to develop this type of partnership that it becomes integrated like any other service. So using data to drive internal and external change. So again, we talked a little bit about this with the rates and going back to visit it, and that it's not just the rates, but that was one example about creating this iterative process where, we're going to try something, well, maybe that didn't work, or we were off the mark a little bit, let's adjust, or this is working great, let's expand it. There was a lot of discussion on both sides about creating this more iterative process. Like, okay, we're really kind of piloting some of these relationships, and so let's launch it, and then let's adjust as necessary. And so really having an open dialogue, an iterative process that's built into the partnership to check in regularly, collecting data on both sides for both what's working and what's not, so successes and challenges. And then that can be used as we move forward and think about, we'll discuss later some of the barriers and some of the potential regulatory changes that could help promote these partnerships. So if you have that information, you say, well, we have this really big challenge because we can't share data because of this regulatory burden, or we can't seem to move forward with the contracting because of this. And that can really help inform regulators and policymakers and folks who want to see this happen. If you can not only have that iterative process, but document what are the real barriers, and if there are things you can't solve between a plan and a community-based organization that you really need additional guidance, you need additional clarification or changes to regulation and statute, that can really help with advocacy in order to inform regulators and really promote these partnerships in the future. So those were the steps that we identified as really important to creating these successful partnerships. And so a term that we came up with to sort of describe these was integrated care services. And so that describes a relationship where really the plan is at the center of the delivery system, and they have the built-in flexibility to use community-based organizations to cover the necessary social services and support that their members need in order to maintain and build on their health. And so that was just something that, the health plans during our strategy session came up with that term as a way to describe how they really saw these partnerships developing. So as I mentioned, we also identified some barriers, and the first two, the main ones that came to light during these discussions were the rate structure, which makes it really difficult for plans to pay for these services in some instances, and we'll get into that a little bit more on the next slide, and then some regulatory and contractual barriers. So now we'll talk about those. So maximize or leveraging the rate structure. So we've seen some changes in recent years, which is very encouraging. So the Chronic Care Act and the Medicaid Managed Care Rule, which many folks refer to as the Megareg, have both provided additional opportunities for these federal and state programs to think about innovative ways to pay for social services and supports through health plan rates and premiums. So many of you may be familiar with one or both of these, but just quickly, under the Chronic Care Act, it's allowing Medicare Advantage plans to build into their bids, the idea that they would pay for food delivery or a home modification, and that would be built into the bid, approved by CMS as, a service that would be included in the benefit package for those Medicare beneficiaries. And that is new, and it allows for those costs to be accounted for. So previously, if a plan was to invest in those things, it may not get reimbursed for those services in the long run. And the same concept has arisen under the Medicaid Managed Care Rule, which clarifies that states can allow their Medicaid Managed Care plans to use an in lieu of rate methodology, which says in lieu of, a skilled nursing facility stay that's not necessary, you can pay for a home modification or other things like that that traditionally Medicaid wouldn't cover, but under this in lieu of rate methodology, they are allowed to cover those social services and supports and build those into the rates so the plans actually get reimbursed for those costs. And why that's important on both sides is because what happens is if they, over time, plans invest in these things because it's the right thing to do and because, members need it and it does result in better health outcomes, they over time we'll see premiums slide, and the California Healthcare Foundation did a paper on this. If anybody's interested, you can Google that and find it. And so over time, the plan's rates and premiums will get eroded because they can't include any of those costs as they build the costs going forward. So if they're spending lots of money on home modifications or food delivery or respite care or stays in assisted living, that are, more cost-effective on case-by-case basis, but over time those costs don't get built into the rate going forward, so their rates actually get reduced over time, and there's less incentive to invest in those items. So this is a really important move that really does indicate the industry and the federal and state government moving towards recognition that these services have costs and they have benefits and they should be paid for. And the second big barrier was eliminating regulatory and contractual barriers. And so there's lots of different initiatives, specifically in California, which is where we were focused for this study. So we have the Coordinated Care Initiative, which is a financial alignment demonstration for those who are eligible for Medicare and Medicaid in 7 counties in California, where they have one integrated plan and where managed long-term services and supports are provided through their Medicaid plan. The Whole Person Care Pilots, where certain counties are been given sort of big grant money from the federal government under the 1115 waiver. It's not really grant money, but it comes in, an allocated amount of funding to look at how to provide whole person care pilots. So again, paying for things that you wouldn't normally have the authority to pay for with federal dollars. And the Health Homes program, which is another pilot in California that's, again, wrapping around trying to provide all those social services and supports and connections to those items that the members need that wouldn't otherwise be paid for. And yet we're trying to do all these things, but the regulatory and contractual requirements have not really been adapted to reflect the delivery of care under this sort of social model. And so it's really important to think about, if we're going to do these more broadly and think about them outside of just pilots, then how do we update the contracts and any regulatory barriers, as I mentioned before. So that's an important step. And again, why it's important to collect the data. If you're getting into these partnerships, where are those challenges? Where are those pain points that could be addressed by the state or federal government? So in looking at opportunities to reduce barriers, integration, so some of the ones that we identified specifically that should be addressed, as I've mentioned this previously, was the implementation of the in lieu of services payment structure. So again, that's in Medicaid, and California is examining how it may be able to use this payment structure going forward, but it is something that has not been broadly applied in California, or I'm not sure in other states, but sort of newish that it's been available more broadly. And so it would be really important for your states to be examining how that could be a way to really support these partnerships, because again, if the plans are not getting paid for providing these services, then over time there involves rate erosion, which means that it is not a sustainable model. So development of clear guidance on what social services and supports can be funded with health plan dollars. So again, we talked about this a little bit at the beginning, where we're talking about how health plan, establishing a discrete set of services up front. So not only is that important for the community-based organization and the health plan in order to develop a strong partnership, to be clear, but it's also important from the state perspective, because there is a concern that if you just open up the door, then you could be paying for anything and everything, and all of a sudden we're spending millions and millions and millions of dollars on lots of social services and supports, and there's no sort of guardrails or utilization management around it. And that is the concern of those in the federal and state government about how do they make sure the benefit is adequately funded and something that they can actually pay for, since currently it is it's just based on need. It's not block grant funded at this moment, at least. And so if they have a list of services that are allowable, that it puts some sort of guardrails around the costs and make sure that they're not going to be all of a sudden unable to fund what they have put out as available. So that's really important, and that's really hard, because there's so many things that could fall into this bucket, and it's hard to make a judgment call on which ones. But that needs to be done for folks in order for everybody to be on the same page. There was a lot of discussion around reevaluating the federal prohibition on paying for housing. We're seeing a sort of shift on this as well. The homeless problem that's specifically really bad in California. And folks really thought that it would be a great help if there was an ability to use these partnerships as a way to pay for housing. And so I know that's sort of far off, but everybody is recognizing that Housing First is a model that's seen some success, and not being able to pay for housing was a really big barrier for getting the rest of the social services and supports and the health care to the members. And so that's a really, I think, big one, a little bit of a heavy lift, but something that came up over and over again, and I know is being advocated for in several other areas. Case management requirements to allow for the use of additional social service provider types. So there's some rules around case management and who can be a case manager, and with the expertise the community-based organizations have on the in the community, and the trusted, messenger role that they often play can be really important. And yet, if you don't have maybe a certain, acronym behind your name, you're not allowed to technically have some roles at the health plan. And then so there was some discussion around, is there a way to ease those so that folks who work at the CBOs can play that role where it is appropriate and makes sense for the member. Another thing that came up was, again, sort of similar to the onboarding process that I talked about earlier. So the creation of some sort of standard vetting process, credentialing, oversight, quality, so everybody is on the same page. So again, thinking about lessons learned from other provider types, rolling out of new benefits over the years, that it was, the plans really felt that it would be important to think about how could we create some sort of a standard onboarding process that would include a credentialing, oversight, and quality. And I know some of those things maybe seem overwhelming to community-based organizations who don't necessarily follow the path of a traditional provider, but there may be some ways to adapt that to fit this model that make a little bit more sense. And so there was some discussion about how that would help promote these partnerships, give it a little bit more validity in the eyes of leadership and regulators, and sort of fit into that, the previous point about case management requirements, right? If you have this vetting and credentialing, you can fit them into those sort of health plan roles a little bit better, and so it integrates with the system. Updates to the network adequacy and access requirements to reflect social services and supports in that delivery system. So it's not the same as saying, you have to be able to get to a PCP within, 30 minutes or, 50 miles or whatever. Those aren't the right standards, but there's really a different way of looking at how these community-based organizations and the social services and supports delivery system wraps around and where you're located. I mean, you're not going to just create a bunch of extra CBOs. A lot of the services can be actually brought to the member's home, so how do you account for that? Those sorts of things really needed to be addressed, because this can really help wrap around and fill in some of those gaps. And so the plans wanted to think about how do the regulators really adjust for that and account for that, and think about how that does fit into how we think about traditional network adequacy and access to providers. And then a really big one was the consistent application of the HIPAA regulations and standard data security certification requirements. So there, we hear this a lot. I hear this, California is very county-based, so we hear this in lots of different initiatives, several of the ones I mentioned earlier, and then also a lot to do with the behavioral health system in California, which is county-based, is that you hear from each entity that you're dealing with a different application of the HIPAA regulations and the standard data certification requirements. And so this goes back to the very beginning where we were talking about some of the steps to successful partnerships. If you can't share the data, you really lose a lot of the value going forward, and being able to prove that that's working or not working, what challenges you have. If you don't have data to support what you're advocating for, or to support expansion of these partnerships, then you're at a loss. And you also are losing a really big opportunity to demonstrate how effective these partnerships can be. And so there is a real need for a federal clarification on what data can be shared, what the requirements are between entities, who falls into what bucket. And like I said, I hear this not just in this specific instance, but in lots of areas where we're trying to integrate across different systems. So I think this is a really big one. I think it's a heavy lift. I think it's long overdue. For those of you that work in this world, I'm sure I'm preaching to the choir, but that is one that, again, came up over and over again. Like, well, we got to this point, and then the health plan told us that they couldn't share data with us. Well, if we don't know any data about the member, how can we be helpful, and vice versa? So I think that is really important. So we also looked at some additional resources that might be helpful to folks as they're building these partnerships. So a directory of local services and service providers that are offered by CBOs, just for a plan to sort of have at its fingertips, you know, a way to access that and be able to refer members, even if there's not a formal partnership, that can make them part of sort of an informal network. Universal community-based organizations agreements and contract templates that could be developed, you know, by including stakeholders and approved by regulators. This again goes back to the sort of, you know, standard credentialing and onboarding process, and thinking about, okay, this isn't a traditional provider, but this is a provider-payer relationship, and so it does need to have some sort of, you know, there needs to be an agreement and a contract about what we're going to do and how we're going to pay for it, and that it would be really helpful to have a sort of stakeholder process to develop that and have it approved by regulators so that everybody knew it was blessed, so to speak, by those who are paying from the federal and state government, that those arrangements would then be okay to move forward. And I think, again, that also goes to making sure that all the services will be built back into the rates going forward. There was a suggestion that we build some toolkits and managed care training for CBOs that would go across sector, including Medicaid and Medicare, so that CBOs could kind of get up to speed on what maybe it would take to get into one of these partnerships, provide resources, a little 101 on how managed care works, and where they can go to start that process. There was also a suggestion to have funding by the foundations of the government for startup grants to sort of get folks going and to start to demonstrate the return on investment. So I mentioned this earlier, that there's some thought around, well, if we just did a sort of lower risk on both sides to get a one-time grant funding, pilot something, test it out, then you were able to show this worked, this didn't, this was the return on investment. That gets buy-in from government, payers, providers, CBOs, and then you know, you have some data to really develop a more thoughtful long-term partnership and to demonstrate that it's of value and should be funded by the government and health plans going forward. And then a managed care training and contract guide for the CBOs. It was the idea that health plans could work with CBOs and stakeholders to think about how to develop these resources, find additional funding opportunities, and really think about how there could be put together to drive internal and external system changes that are really needed to develop these partnerships. So key takeaways. So the integration of CBOs and health plan networks does help address both social and medical needs, specifically for older adults and dual eligibles, which was the focus of the SCAN Foundation work. And so I think it's, I mean, we started with the premise of that, and I think we want to also remind ourselves that that is, you know, there's proof that these partnerships work, and thinking about how to further integrate them makes a lot of sense. There is a pathway for creating successful partnerships, but the current system is not really set up for large-scale adoption of these integrated networks. And so how we've talked about how, you know, maybe some advocacy around that, or doing more pilots, more foundation funding or external funding to show the return on investment so that this becomes more of a widespread model would be really helpful. that health plans, CBOs, and policymakers should work collaboratively to think about how to develop a more coordinated system of care, because it takes all of those parties to agree on what we're doing, what we're paying for, what the benchmarks should be, what the desired outcomes are, how we move it forward, what the rules are. They all need to be coordinated. And so, you know, knowing that we need to provide access to social services and supports and make them easily accessible, how do we get there? And it includes really bringing all of those parties together to examine how to make that happen. And then all stakeholders should think about their role in reducing barriers, increasing integration, advocating for policy changes that could really help drive these partnerships forward. And I think that we have come to the end. So we have just about 15 minutes here for questions. I see some coming in, but I think I will pass it back to Steve to see how we handle those questions. But thank you so much.
Okay, great. Thank you very much, Athena. Yes, everyone, it is time for the Q&A portion of today's webinar, so please send in those questions. Have them at this time. And Athena, if you are ready, we'll go right to the questions. The first one here for you. Can I get the name of the CHCF paper that you referenced?
Let's see. It is called Paying Medi-Cal Managed Care Plans for Value. You can just Google Premium Slide and CHCF, and it will bring it up.
All right, wonderful. Next question. Have any CBOs who are also Medicare providers been able to obtain assignment of benefits from hospitals or physician groups to directly bill under MACRA?
I do not know the answer to that question. I apologize. I think that's probably a question for a regulator.
Oh, fair enough. Okay, next question. Do you have a sense if health plans would prefer to contract with national CBOs or regional CBOs? Both have their advantages and disadvantages.
And that's a really good question. You know, I think where in the folks that I talked to, which of course was limited to California and to a subset of folks who have had some experience with these relationships, it seemed to be that regional relationships worked better where there was, you know, some sort of name recognition in the community from the CBO. You know, those initially seemed more attractive because that was the value that the CBO was really bringing, that they were on the ground, they were trusted in the community, and, you know, could sort of just be the eyes and ears of the plan on the ground, so to speak. However, they come with challenges, as you mentioned, because they are often less sophisticated. So if you have a, you know, larger CBO, so there's some in California that aren't necessarily national, but are, you know, bigger and more sophisticated, and they've also seen some success in being able to come in and build a network around a specific set of services, and they often have an easier time with the contracting process and the invoicing and the building of rates and all of those things. So I think that, like you said, there's sort of both advantages and disadvantages, and I think where that can be identified for each partnership is, again, in that RFI, RFP process at the beginning, because plans will have different needs, and so I think they can see the advantages of both, and it will just kind of depend on the specific set of services and problem that they're trying to solve for with that partnership.
Okay. Next question. Any experience with criteria to evaluate whether or not CBO is ready to partner with a health plan, similar to pre-delegation checklist for entering into first-tier downstream entity?
Yeah, I mean, I think that's starting to happen. So I know one CBO in California, what they do is actually set sort of a consultant agreement first, so that the two parties can explore, well, what is your need? How does this work? Are we a good fit? And maybe at the end of that, they decide, well, no, we're not the right fit. You should go with, you know, a more regional, or you should go with a bigger, or you need something else altogether. Or, oh yeah, we can do this, and now we're both lined up in a, you know, in a pretty pretty positive way to move forward on creating a longer-term partnership. So there are ways to do that. I think that's part of what everyone's exploring and thinking about. Some of those resources I mentioned at the end, like could we create some sort of onboarding process, some sort of standard contracting, rules that the government could also weigh in on and quote unquote approve, so that folks would feel more comfortable like these are the steps that need to happen in order to make this a viable partnership. So yeah, I mean, I think those are starting to come, but there's definitely room for more to think about how those could be leveraged and created and expanded. I think folks are really hungry for that kind of information.
All right. Next question, Athena. Do you have any resources for assistance with payment arrangement options between CBOs and health plans?
So, I mean, other than, finding yourself a wonderful actuary, which I am not, I think, there's so many ways you could structure these payment arrangements. I mean, I think one of the first steps is making sure that the plan feels like those are services that they can get reimbursed for under Medicare or Medicaid, depending on the population or both. And so I think you can look at, current contracting arrangements, pay-for-value arrangements. I don't think there's nothing that I'm aware of that gives you a great resource to walk through. I think talking to your partners and seeing what's worked for them and what hasn't goes back to, again, collecting the data on what's working and the challenges, and then talking about, well, what structural changes do we need to make that happen? And so the payment can be really tricky. I think from what I've heard, some of the most important pieces is to make sure you know up front what the real costs are to the community-based organization and what value it brings to the plan. So really doing that homework up front and having some, real hard data on what are those costs and what are the potential, cost savings that can result, and how do those two things work together to create a payment arrangement that is beneficial to both parties. I mean, that's the building block, and sometimes it's just can be so different based on plan, based on, state, county, area. So I think, it involves getting those initial pieces, and then I think hiring some well-versed actuaries would be my my thoughts. But yeah, sorry, not a lot out there that I'm aware of.
Okay. Next question. What are some examples of the types of services CBOs are offering?
Yeah, so we have a list at the beginning, so things like home modifications, food service delivery, I would say some intensive case management. So a lot around in California, there's been a lot around sort of helping with transitions of folks from nursing homes or unnecessary hospital stays back out into the community. So making sure so a plan can't, just send them out without anything. People don't generally leave the hospital or leave the nursing facility without needing some sort of supports around them. So sort of providing, transitional help with those transitions and helping coordinate all the social services supports that need to be around that person in order to help them stay in the community. That's been a really big one. Recuperative care, figuring out how to help with assisted living access so that they don't have to stay in the hospital or in a skilled nursing facility if they could go into a lower level of care. So helping with those transitions. So those are some of the ones that have come across in my research.
All right. Next question. Can you speak more to clarify to your experience of case management requirements?
So this came up in the discussion with the health plans, and I think it's maybe something specific to California, I'm not sure, but they felt like there were some barriers around the requirements and qualifications for who could be a case manager, and that reducing those, not reducing the requirements, but, thinking about how to restructure them to provide additional flexibility so that a case manager could potentially be somebody at the community-based organization who's dealing more directly with the members and can be the eyes and ears of the plan on the ground. Maybe it's someone at a homeless shelter because that's the only place that this, member goes, and so that's really the best person to be their case manager. And so how can they build that into what they're doing as a health plan? And so I think just making the case management sort of broader, making it so that it's something that's paid for, so that those things can be passed down and really developed so that you're meeting the person where they are and not blocking it in to a specific description.
Okay. Next question. One challenge that we face is that the philanthropic world, whose dollars we need to launch our program and proof of concept, believes that the health plans and hospital systems should pay for these interventions since they seek to lower healthcare costs. But the healthcare players don't want to make the investment until the concept has already been proven. Can you help me to navigate this catch-22?
Yes, this is the chicken and the egg situation that we do run into. I mean, I think part of it is education and advocacy, as I've sort of been a theme throughout, the recommendations that came out of this issue brief. But, it is unfortunately a little bit of, as you say, a catch-22 or a chicken and egg situation where, the health plan leaders can be very blunt that they've had a hard time getting their leadership to buy in on something when they don't see the return on investment. And so again, it goes back to folks really have to buy in at the leadership level on both sides to make these partnerships work and be willing to say this is a long-term strategy, and part of that strategy is building the data and the case to that it shows the ROI so that there will be more investment by the government. There will be more investment by the philanthropic world to say, these work, we want to see more of these, this works, this doesn't. I mean, again, sometimes maybe starting smaller so that you don't need as much funding. So say we want to do this small pilot with, X number of members, and then that helps build the case. But I do think you just have to get, really try and make the business case as much as possible, get the buy-in and the commitment as you're talking to foundations or other organizations that you're trying to get funding for about how this is new and this innovative. And yes, the system should be incentivized, but as we've gone through, there's lots of barriers along the way that make what would seem like a really clear incentive. There's things along the way that right? And so educating them about, well, this is why we need some funding at the start. We need to build this infrastructure, and there's no funding for that in the current system, and making sort of that information available to those entities. But it is, it is the sort of question that we're all struggling with is how do you prove the ROI? But you have to prove the ROI before anyone wants to fund it. I mean, I think that is an unfortunate place, but I do think there's a lot of opportunity here if you get two organizations that are committed to doing it and willing to look at the long-term vision. You can start to build small examples of how it works, and then folks want to build on that.
Okay. Next question. Other than area agencies on aging, what other CBOs are involved in integrated care?
So all sorts of CBOs are, I think could fall into this bucket. In this we talk to folks at, Meals on Wheels programs, homeless shelters, intensive case management organizations. So I think there's lots of opportunity for folks that are seeing these people come in their doors, even so religious organizations that help support folks. anywhere where you're coming across folks that are part of this system and maybe they're not accessing their health benefits in the way that they should, I think there's an opportunity for those organizations to step up and think about where their role could be. Now, it may not always work, but I think, I definitely wouldn't put any limits on it. I think anybody who is serving these folks, part of the social safety net, has access to social services and supports, or can help create those connections, almost even sort of referral agency kind of role of a community-based organization, just connecting people. There's a lot of discussion about people just don't even know what there is out there, and the plans don't know, the members may not know, so there's a lot of opportunity there, I think, for just being a connector in the community. And so, yeah, I think there's lots of opportunities out there, and I wouldn't put any limits on who could potentially be part of this.
Okay. Is there a site you can refer me to that specifically spells out typical ROIs or examples of data that has been successful as selling points to health plans?
So I don't have a specific site. I do know that there's a group, I can't think of their name right now, but there is a group of folks that came out of a number of physicians who were frustrated with this exact problem. Like, they see somebody who just keeps coming in with the same problem, and, if we don't address the social determinants of health and get them access to social service and supports, they're just going to keep, cycling through the emergency room unnecessarily. And they're building some resources around how to make the case for ROI. I can't think of their name right now, but I bet if you Google around a little bit, you can probably find them. They're doing some work around trying to get this information out to the public. I know they've had some press recently, and I apologize that I can't think of their name at the moment, but there is some work being done, and you can feel free to send me an email reminder, and I'll try and I will try and connect you with them, because there is some stuff being done that's really exciting.
Okay. So Athena, earlier you were talking about some of the key takeaways, and you were talking about how there's a pathway for creating successful partnerships, but the current system is not conducive to large-scale adoption of integrated networks. Can you tell us why that is, and if there are plans to move in that direction in the future?
So I think it's not, one, because this type of partnership doesn't necessarily lend itself to that widespread adoption. It's really about what's happening at the local level, who are the local resources, how does that happen? So some way it sort of has to exist at that level. But also I think there's just some, there's some steps being taken more broadly, like the Chronic Care Act and the use of in lieu of services. But the system more broadly doesn't pay for or recognize that these are part of the system. These are part of the healthcare system now. And we all know and believe it. Folks on the ground understand it. But I think the rest of, like often the regulations and the contracts and all that takes time to catch up to what's happening and what people see on the ground. So it goes back to sort of the last question, and that folks are, like these doctors finally just started this company to show the ROI because they were so sick of watching healthcare dollars be wasted and care be delivered poorly because we were ignoring the fact that someone was homeless, or we were ignoring the fact that someone had a substance use disorder problem, and nothing else could be addressed until that was addressed first. And so I do think that we're seeing the shift. It's just slowly happening, and it's unique in that it really has to be both local and sort of more broadly made so that made flexible so those local relationships can be developed.
All right. Well, Athena, unfortunately, we've reached the end of our hour here, and we're just about out of time, but I want to thank you for joining us today for a great presentation. Thank you so much.
Thank you. Have a great day, everybody.